So this is a session on body and beyond social construction of health and medicine. We have an esteemed panel here. Dr. Gita Chadha is a faculty member at the Department of Sociology, University of Mumbai, and works in the field of critical science studies, specific focus on women and gender. Please play the slides continuously. I'll quickly go through them. There is an introduction later also. Dr. Bindhulakshmi Pattadath, she is currently Associate Professor and Chairperson at the Advanced Center for Women's Study in the School of Development Studies, Tata Institute of Social Sciences, Mumbai. Dr. Kavita Arora, co-founder of an organization called Children First. We'll hear from her. She is working in mental health field. She's a psychiatrist, a child psychiatrist. Next slide. Mr. Arnav Sethi, he's recently completed his MPhil in sociology at Delhi School of Economics, University of Delhi, and his research was in music and mental health as cultural and clinical concern. Sensorily speaking. Priyanka Padhy, she is an assistant professor at the Department of Psychology, Lady Shri Ram College for Women. And she has done studies on resilience in chronic diseases in children. And we'll hear more from her about her studies and about her in the next panel. Next slide. Dr. Sabah Siddiqui is an assistant professor of psychology at Kriya Institute and honorary research fellow at the University of Manchester. And she has some brilliant work on the role of faith. We'll hear that. I think we'll listen to what she has to say. She has published several papers on diverse topics concerning mental health, gendered violence, cultural and post-colonial studies, the sociology of religion, and the history and philosophy of psychology. Yes, so we'll start the session now. Good evening, everyone. I'm Beena Bansal, and me and Dr. Gita Chadha, who is a sociologist, and I'm an endocrinologist. We have been discussing medicine from different angles. We have been talking about how do people interact in a clinic or in a hospital, and how these conversations happen and how much they bring in what is happening around the whole thing. It's not just the clinic where this conversation is situated, but a lot of other things may be influencing that. For example, from where the person is coming to the clinic, the psychosocial context of that person or patient. I don't even know if patient is the right word, because there has been a debate of whether the word patient itself comes with the implication that that person is a passive, vulnerable recipient of care, which may not be the case. Especially in today's scenario, medicine is changing very fast. It's no more that a person is sick and goes to a doctor. It's gone beyond that. And that brings the complexity, because now many diseases are just statistical diseases. We talk about things like diabetes and high blood pressure from my point of view. I'm sure other specialties have their own challenges, but most chronic diseases, because that's the predominant thing nowadays, we manage them with the point of view that if we manage 100 people with diabetes, these many percentage of like 30 out of 100 maybe would maybe have a longer life, or maybe not land up with heart disease. So 100 people getting medicines, and we would be influencing so many people. So that's how the concept of risk reduction works, and it's a difficult concept to grasp, explain, and it brings it with its thing that the choice of taking that medicine should be with whom. So all those, I'm keeping these things open. I will not dwell much into this. The choice also is important, because is there a should there, that person should be taking medicine, should be doing a stricted, like regimented, should be leading a regimented life. Like, are we all being clones of each other, that we have to go to the gym every morning and not have any dessert all throughout the week? Or can we enjoy small things in life. I mean, from a doctor, it's a difficult thing when I tell people that you can enjoy things sometimes. You don't need to always restrict, because ultimately, why are we living if we can't enjoy small things? So, but what is pleasure? All those things. So there are a lot of things which come into discussion because we are treating things which are not causing any trouble right away, and we do not know what is going to happen. We are just predicting something. So that's, I think, one important part, because of which it's even more important to discuss humanizing medicine. It is actually not just treating pain or illness right now anymore. It's not about just acute care. uh, so with that introduction, I will pass on the mic to Dr. Gita to carry the conversation forward.
So I welcome everyone, and I'm very happy to be here with Bina. And let me just give a quick background that we worked together earlier on something called FEM 2020, which was on looking at gender in medicine. And it was a very fruitful but difficult exercise of social scientist, psychologist, anthropologist, sociologist, and activists, some coming together to talk to medical practitioners. And we faced the challenges at many levels. One was, of course, the level of the language itself. So, how does one make the language of social science accessible to medical practitioners was a big challenge and will continue to be a big challenge. I can say this from my experience of working in feminist science studies, where we as sociologists and feminists attempt conversations with people in sciences and technology, largely physicists, biologists, and there's an impatience, with the language of social science. Why are you complicating things? So hopefully that methodological, respect for the language of each other's disciplines needs to be for any form and interdisciplinary dialogue. And of course, the question also is of a fair amount of trust in the effort and the activity, that it is going to lead somewhere, and we are going to struggle, we are going to judge each other. Sometimes we are going to other each other, as Kavita was pointing out to us, that we need to be careful not to do that. So but I think what brings us together is the need and the desire as to work towards a more inclusive society overall, and work towards medical practice within that, and medical theory within that, and how to open it up and make it more inclusive, make it more democratic, make it more participatory. With that kind of desire, I think we've undertaken some of these conversations. As people in the social sciences, of course, we tend to look at the historical emergence of modern biomedicine, and try to see how the promise of it, the wonder of it, the beauty of it, and yet the kind of challenges it is posing today to us when it gets practiced, as another friend pointed out, which I was just sharing with with our panelists here, is that when we live in a highly corporatized medical community, also where we deal with the questions of constant pressures from the industry, from the state, to do what is required. What should medicine do? With those kind of pressures, the individual medical practitioner is struggling. Like Beena was saying, that it's important to get a collective to reflect upon what is required, what is missing, where did it go, how did it go, why did it go. So this missing component of what we've tried to call human, also we need to sort of problematize. I hope we will do that as we go along. And the word problematize itself, I can hear that might become a problem. So let me just say simply that we are attempting to ask questions and find ways of coming together. Yeah. So that's really hoping that this dialogue will get us somewhere. And So we planned this conversation in 3 rounds, but of course I'm hoping that we will just cut across and flow into each other's conversations. We've also set out a certain order in which each of the panelists will speak. The 3 rounds, largely, broadly, we've sort of organized into 3 themes, which is the first to ask the question about what is human. And it seems like a very silly question, but it's a very important question that has engaged philosophers and writers and thinkers over centuries. And then we move on to the question of the body and how the body gets constructed in medical theory and practice. And then we move on to asking the question of what is the meaning of going beyond and how do we think it through. Yeah. So before we start the rounds, may I request our panelists to introduce themselves briefly? Kavita, can we start with
Thank you, Gita ji and Bina, I think, for conceptualizing this platform. I think I'm really grateful that not just that I'm part of it, but that this platform exists. So my name is Kavita. I am by qualification, I'm a child psychiatrist. I practice right now in the NCR, and I'm co-founder of an organization called Children First. The reason I'm here is not necessarily only because of my professional sort of leaning. I think the questions that Gita ji was referring to and the dilemmas that Bina is referring to are dilemmas that I've faced right from the beginning. And in different ways, the reason I chose psychiatry as a profession came from the fact that these free-floating dilemmas were there every day as a medical student and onwards. But one did not find a forum in which, apart from the body, could be discussed freely, without judgment, and with a level of understanding. And therefore, I took to the mind. And I thought, maybe that's where one will find the space to create the safety to talk about not just organs and not just systems, but something beyond the body. And that's been my interest right from the beginning. I also bring in perspectives as a carer of someone who had mental illness. One of my parents had mental illness since I was quite young. So I've also been on the other side as a caregiver. And of course, all of us have also, most of the time, gone to a doctor. So, I'd like to make sure that one is keeping in this discussion all those hats on, because I do feel that being human means all of them at different times.
Thanks, Kavita. Arnav?
Yes. Thank you so much, Dr. Chadha and Dr. Bansal, firstly for having me here. And I actually completed my MPhil dissertation recently at the Department of Sociology at the Delhi School of Economics. And so my work is really concerned with actually trying to find a sort of therapeutic possibility between music and psychiatry. And so my dissertation titled Sensorially Speaking, Music and Mental Health as Cultural and Clinical Concern. I'm actually very grateful to be here for a lot of reasons. And as Kavita ji also said, that primarily because such a platform does exist, and for this sort of meaningful conversation to take place between social scientists and medical practitioners. And so my work is actually broadly focused on the sort of socio-cultural shaping of illness experience and on processes entailed in constructing the legitimacy of treatment modalities, both from patients and practitioners' point of views. And I'm also trained in Hindustani Indian classical vocal music myself. So I'm also sort of concerned with developing what I think are non-linguistic and non-verbal modes of emotional expression for psychiatric patients. And yes, that's all.
Priyanka?
Good evening to all present. Thank you very much to Dr. Bina, Dr. Gita. My association with both of you goes back to FEM 2020 and many wonderful conversations that we had on that platform. I'm glad that there has been an extension and this year where we are thinking of so many more conversations in this similar sort of a vein. I liked what Kavita said earlier about donning multiple hats. So I'll briefly talk a little bit about the different hats that I'm donning. The first one is that of a researcher. I'm currently a doctoral candidate at Center for Early Childhood Research and Development at Jamia Millia Islamia. My research work is on the social ecology and the social ecological construction of resilience in children with chronic illness conditions. I'll speak a little later about the research work itself. I'm also a faculty member at the Department of Psychology at Lady Shri Ram College for Women. So sometimes I also speak in the voice of a teacher. And thirdly, which is the voice that I have recently sort of recovered in the recent years. It has taken me 3 decades to be able to reach that point. I am an adult who's living with an illness condition, a chronic illness condition through a blood disorder. And although I was born with it, I have been only able to find the voice around it in the recent years. So for me, this particular platform is also a platform where I can speak beyond the ill self. So my self-definition, which goes beyond illness, that beyond is what I'm exploring here. And I'm so glad that there is a platform such as this where we get to explore along with doctors, along with medical practitioners, and straddle these two zones of patienthood, but also much more than that. So really grateful for that. Thank you.
Sabah?
Good evening, everyone. Yeah, thank you for inviting me to this panel. My name is Sabah Siddiqui. I am a clinical psychologist, and my research for the past decade has been on traditional medicine. So my research has been trying to study about culture and mental health. And in my doctoral work, I was looking at the meaning and significance of faith healing at a shrine, the Mira Datta Dargah in Gujarat. This is 500 years old, so it would have been an interesting project in its own right for its historical and cultural relevance. But I was actually interested in it because it had India's first and only government-funded mental health program within the Dargah. So what interested me was that how did people, devotees of the shrine, how did they take to the medical treatment, the psychiatric treatment that they were being offered as part of the mental health program, and how did they make sense of it between science and faith? I think what my research then shows is that medical pluralism, people accessing more than one treatment modality is a complicated process, but it also involves a very human aspect in all of us in trying to access care and trying to reach healing. And I think I'd like to bring some of those aspects to the discussion later on. Thank you.
Bindu.
Thanks, Gita and Bina, for putting this panel together. I'm really looking forward to the conversation. So myself, Bindhulakshmi, I'm a teacher and researcher based in Bombay. Currently, I am an associate professor at Advanced Center for Women's Studies at Tata Institute of Social Sciences, Mumbai campus. I've been trained, my early training is in anthropology, then I moved to sociology. Then last several years, I've been associated much more with gender studies department at TIS. So I've been as a feminist anthropologist, we do theorize body. We do theorize body in the classroom, also bring it in our empirical work. But I also looking forward to this conversation from practitioners, trying to look at bodies from multiple contexts. So my work primarily, it is interdisciplinary in that sense. I do work in the area of feminist gerontology. I do look at the critical disability studies and then mental health. This is also different context and different time span. I have done all of this work and trying to make sense of how do they look at perspectives from people who have been subjected to various aspects of looking at mental health, disability, and aging gendered bodies. So I'm looking forward to more conversation. Perhaps today I will try to bring in some of those contexts from my own empirical work in the field. And thank you so much for having me.
Thanks, Bindu. So now, I will don only the moderator hat today if possible, But just to briefly say that I have been working in at the intersections of what we call the sociology of science and sociology of knowledge. And one of the places where I position myself is where we recognize that as sociologists, in the inception of our discipline itself, we privilege science, its method as an institution. Of course, because we are all born, quote unquote, within the Enlightenment period and with the idea of the Enlightenment modern. And so science and scientific reason was primary, central, and privileged. So a lot of our critiques of that come later in the post-war periods, and as a discipline around the 1960s, we start seeing a critique of science emerge, both internal and from the outside. Yeah, but I also moved in looking at science from a feminist gender perspective and trying to see how science actually could, because in the women's movement, science has played a dual role. While on the one hand it has been extremely emancipatory and liberating, on the other hand it's also been very binding to us, and we find that it tends to sort of reproduce the kind of social biases and social understandings of gender and that exist. So it's been a very difficult difficult relationship for us. So my own work, of course, was a very small study on scientific creativity and knowledge production amongst physicists, biologists, mathematicians, those who do very so-called very abstract work. And I was trying to look at the role of intuition, and I was trying to argue that intuition, which is a feminized category, a feminized epistemic category, is very much a part of the production of scientific knowledge, and yet it gets mostly erased to present knowledge production in science as being very linear and very rational. On that some other day. So let me just start with the rounds. And when Beena and I were trying to think about this, conceptualize and how we would go about it, there were just a few conversations that we were having, and coming from FEM 2020, and we were trying to understand what we were missing. And perhaps with a very quick word that came to us was, we're missing the human. Are we missing the human touch? Are we missing the human perspective? Where are we missing it? Is it in the clinic? Is it in the theory? Is it in the discourse? Where are we missing this so-called humanness or humanity within medicine? And actually, if we go a little, just a brief etymological search on this whole idea of human will also make us understand that maybe we want to discard this notion also and replace it with a better notion. So let me propose this to you. And then start the round of discussion, because the word human always comes in binary to that which is non-human, which could be the divine, which could be the animal species, which could be birds. The human means, in a way, it's very anthropocentric in the sense that it by definition means somebody who is man, etymologically, whether you use the French or the Latin origins of it, and somebody of the earth. You go deeper into it and you start seeing that it is, the species get defined in terms of very definite characteristics: intelligence, verbal ability, bipedal, all of these characteristics. And then the term starts getting very constructed. Yeah. I was trying to understand, say, in Indians, suppose if I have to talk to somebody and say what we are doing here, what are we missing? Insaniyat, matlab, kya nahi hai, manavta, what? So it's more a question of something which is trying to burst forward, asking for a voice in a space beyond what we all know as the medical gaze of the clinic, yeah, where the patient is objectified, where the knowledge is standardized, where the voice of both the patient and the doctor, I would say, is lost within the bigger discourse. So I'm going to start with Bindu and ask her to dwell upon it. So, Bindu, what I'm trying to also grapple with is that uh, when we are talking about also restoring or reinserting the human, we are talking about restoring a person, right? It's the personhood that we are wanting back into the system, the personhood of the doctor, the personhood of the patient. Yeah. Sorry, Bindu. So, if you could just sort of just free flowing share your thoughts.
Thanks, Geeta. I hope I will be able to have some justice to the conversation. So one thing immediately when the idea of the human, I was trying to think about. Let me go back and think about, for example, in Racina's work, the animals, people. So the animal in that novel is somebody who has been gone through a history of a catastrophe, of an industrial disaster. Somebody who has been gone through with a back twisted and walking in four legs, who has been represented as the animal. So, but everybody has a history. Everybody goes through a historical process. The idea of when you talked about the insanity, when you talked about human, I was trying to think about when it comes to the clinic, or it doesn't need to be the clinic, it can be the gaze of an anthropologist, perhaps. How do we see that body? Do we see the body in a historical context? Do we see that body with a history? The socio-historical process through which that body goes through. So, at the point here is that the way in which we try to recognize body, of course, it goes through a lot of binary that we can come in as we speak. If I try to think about in the context of clinical perspective, there is this idea of normal and pathological, which we have theorized enough. As sociologists, we know the how the normal and the pathological has been constructed. But in that process, whichever disciplines we come from, there is an idea of do we go back and historicize and look at the historical context through which we see and gaze upon a body, and whose gaze, and particularly when a powerful gaze comes to someone and look at, and then I say that you need a treatment, you need to your condition needs to be rectified. A process of dehumanization perhaps happens in that process when we try to see, and I do not want to say that it's only medical science do that. All of us in the process of, as you said, that in the context of, how do we look at post-enlightenment period of the idea of disciplines came in, and then how we started looking at context, and we don't then look at the precarity through which bodies get constituted. And the gaze often then comes to looking at the vulnerable without necessarily trying to understand the historical context through which bodies go through and comes to be. So perhaps in the later round, we come back to the context of my own work. I can think about, for example, how do we see aging bodies as always as inevitably degenerative and going through a linear process. I'll come back to that later. I don't know how much time I have right now. Perhaps I'll keep it in this moment to come back and historicize the context and say that everybody has a history. And
Yeah.
when we don't recognize the dehumanization, perhaps happens over there.
Yeah, yeah. Thanks, Bindu. I'll let Sabah pick up from there on sharing her thoughts about what is the human, who is the human, who is not the human. How do you look at it, Sabah? What does this term mean?
I think I'm going to be starting off from like my work as a mental health practitioner and researcher in mental health conditions. People who are suffering from mental illness, and here, of course, this is medical terminology. This is a group of people that they are made highly vulnerable because they cannot advocate, or it is challenging for them to advocate for their health and their treatment. And in the modern period, what we have seen, by modern period, I mean like the last 200-300 years, they have been treated as less than human. And now this has been attributed to perhaps a diminished capacity to engage normatively with societal expectations of what society expects us to do, how it expects us to function or work. And I think so this constituency makes us look at the question of the human, that, it is that who is human, what makes us human. And I think what is attached here is that who gets to have a say in what their medical treatment should be like. So if all humans are the subjects of human rights, not all humans have the same rights. And we can see that in with many different kinds of groups of people, right? But at least for right now, I could think of a very interesting text by Judith Butler, titled "Frames of War." When is life grievable? And it's in times of war, we see that not all lives are equally important, or not all lives are treated as grievable enough, right? So this actually makes us question that, do we not need to start the conversation on human is to also acknowledge that our idea of the human is also something that requires us to recognize the other, right? To say that, okay, this other can be recognized as human, can be represented as human, because that is not our history. We have not recognized other humans, other kinds, other groups of people as human. And I think so this is then an ethical act to ask the question of what is human, is an ethical act that we need to ask, that, unless we can inquire into this, that, who is human and what makes us human, we'll not be able to acknowledge that this a foundational problem that we have here is that historically all humans are human, but not all humans have human rights. So I think I'd like to explore this more.
Sabah, that I think you put it absolutely, well, because we all know that, the common refrain, some people are more equal than others. We tend to use it largely in terms of social privilege. But here, what we also need to understand is how the biological human also is constructed around a very ideal idea of who is a human, and therefore that, the rest is less than human, stigmatized, marginalized, basically not human enough. And I'm sure Bindu will speak about it when she speaks about her work on disability. Also, let's draw in Kavita. Kavita, as somebody who has, with your, medical education, as you've often spoken about, how does the human being, human, get constructed in medical science? And so, and you've also spoken about how you've intimately cared for somebody with a mental health condition. So how do we look at, how do we question the way medical science actually constructs this idea of the human as just the body, the biological body? I don't know. Want to hear from you.
So I'm trying to go back to the time that I started training as a doctor with my peers and colleagues. And what comes back to me is how we got constructed as doctors as a subset of humans. And I think that's hugely important to look at. So while we look at how the position of the patient / client / seeker, it is also very important to see the value and the journey of this young medical student who has entered into this noble profession, with the understanding this is going to be hard. And then, the first thing you do when you enter is anatomy, where you learn about the human body. And the way that we used to do it was to look at the deceased human body as a cadaver. And that's not something you get prepared for. Yeah. So if you have 120 people in a medical college at the age of 18, entering the space where they are interfacing with the human body that they are going to cut up. This in itself, this act of
brutality of the human body is required. So if I look back and I say, was there space to address how I was feeling as a medical student when I, for the first time, faced this as a task? The answer is no. There was no space. The implicit message is, get on with it. You're here to be a doctor. And I think that's where the process starts of defining what kind of a human are you going to be if you're going to become a doctor. So implicitly, the message is, those feelings have to be locked away. The ickiness of it has to be put away. If you want to go ahead, because you're just a first year. So your seniors tell you that, but there's no, at least in Indian medical education, there is no forum where any of this can be addressed without judgment. And I think each one of us needs to understand the journey of the doctor, who then goes on and speaks to the tissue, handles the eyes as a separate entity. And what is this 18 to 23-year-old going through over a period of time, interacting with people, facing death for the first time? And where are the forums to discuss that? So what is of value in this journey is defined by the larger social discourse. And the incisive diagnostic deficit finding ability is what is valued. You're a good doctor if at the end of your MBBS or whatever you're doing after MBBS, you're able to pick up the abnormality even to the smallest extent. Yeah, this is of value in medicine in the way that it is taught. And these are very normal words. These are very, very commonly used words. This is abnormal, this is pathological, this is illness, find the deficit, find. If you take the time to look at strengths, resilience, relationships, the larger context, you're losing out time to diagnose. So I think just sort of helping us see, one, in the journey, what is being focused on, and therefore what is valued, and therefore what is internalized as this is what you need to be good at. And then once you start meeting people and you realize where you lack, and you start meeting 20 people in a day, all of whom are unwell, unhappy, in pain, confused. And I'm deliberately using emotions and non-medical words to say that there is so much non-verbal, as Arnav said. It's not that as a doctor, I was not absorbing this. I was absorbing all of it. And yet, if I'm meeting someone for 10 minutes, and the larger social discourse running in my mind is that this 10 minutes will be of value if I'm able to get to the sorting out of the puzzle, and it will be absolutely invaluable if I don't get there. So while I can see someone crying, at the same time, if I do not locate what part of the body is causing the pain, am I really helping this person? And I think this definition of defining what a good doctor is going to be is carried through in our hierarchies of when somebody is idolized as a good doctor, or when one of the seniors is seen as, oh, that's the best person. The stories around what does this mean to be a good doctor is something that we all internalize over a period of time. And I do think some of that is starting to change. But the only other thing that I would like to say is that the subsets of each of these specialties is so different. A trauma specialist, for example, somebody who is working in the acute emergency care and has to look at seconds of time, versus someone like me who's practicing in a clinic with mental health, where I'm going to allocate an hour to even start off about the life, is vastly different. And therefore, I think the kind of person and the kind of interaction that we eventually end up seeing is vastly different across all these specialties as well. And I think all kinds of subsets exist even within the doctor population. The very fact that we are talking about humanizing right now means that we've traveled a journey to dehumanize maybe, and now we are picking up on the threads to say, hey, something's missing, and let's sort of do something. And I think there are enough people who are saying, let's do that. But I do think that in many ways, just as we are looking at interactions and we are looking at the two humans in that interaction, the doctor and the patient, we have to look at the larger discourse that puts value on these positions and that is internalized by both these humans. So if I, as a doctor, approach another doctor, I'm automatically in a position of a patient or a caregiver, and I've been there. And despite my profession, despite knowing the doctor maybe, there is a very significant shift in how I present. When I am either the caregiver with the patient or I am the patient myself, there is an automatic dawning almost of a lower position. Ki aap hi batao, doctor sahab. My brain says this, but actually I will. So even as a psychiatrist, if I share my journey that at one point in time, I went and consulted another psychiatrist for myself. Now, who will know me better than me? And who will know my internal processes better than me? But I was not willing to accept a diagnosis for myself until it was validated by the other psychiatrist. And this is what is seen as valuable, even in our profession, that you cannot self-diagnose. The power should be in the hands of someone objective, and that person will tell you that your thoughts qualify for depression, for example. So I think these are just questions that that I'm constantly, sort of bringing up, and these are dilemmas. But I think the question is very important. What is this humanness or this human? But how do we arrive, or how did we arrive in medicine? And what is of value in the doctor-patient interaction in the larger discourse? So I'm going to stop here for the time being because I have a lot more to say. But
yeah,
maybe later.
we are just so looking forward to that. Thanks, Kavita. I think you really put forward this whole question of the good doctor as a good human being and who has to almost play God, and it's a very difficult terrain to walk. And I think individual practitioners probably the dilemmas are immense, right? And I think you're absolutely right that if this kind of a forum where we can meet practitioners who are willing and wishing to go beyond the discourse that they've been part of, that's enough of a window. But I think last time in Fem 2020 also this had come up, and Beena and I had talked, but today what you're saying also reinforces this. And I think what we need to really look at is the pedagogy, is medical schools. We really need to look at how to sort of work with the syllabus there, how to do. So, I'm sure Sabah will speak about, and maybe Bindu will also, but the famous work of a thinker called Michel Foucault, who talked about the birth of the clinic, the emergence of the clinic, which was the medical hospital, okay, which was a teacher, where you taught and studied the human body. And there is where this idea that, you have to separate, two levels of separation happen. That you have to separate yourself from the patient, okay, from the patient's emotions, from the patient's feeling. You have to look at the body, yeah, and look at the body parts. And that level of separation, that level of alienation between and the other, which you have spoken about, is the alienation from your own humanity, from your own self, which also you have to effect in order to become the successful doctor. Yeah, so I'm really glad, and I hope you speak about it more in the next round. Arnav, we are very eager to hear what you have to say on this idea and notion of the human, and whether it is a good notion to hold on to, or do we even need to go beyond it? Anyway.
Yes, thank you so much, Dr. Chadha. And what Kavita ji said is actually really, like, I'm really taking from what she said, and like I'm going to just pick on that. And so I just like to begin by saying that as a sort of neophyte in the field, I'd just like to begin with this observation that sometimes it does appear that we are speaking in echo chambers. And so again, I don't think that the relevance and significance of such a platform can really be overstated. So again, thank you very much for having me. And so yeah, on this question, I just like to take on from what Kavita ji said about how the medical practitioner is valued on the basis of how they sort of locate what part of the body is really causing the pain. And so I don't want to really talk about, like, I don't want to present a sort of scathing critique of reducing sort of all of diagnosis and treatment to the body, because I think that might just be a gross generalization, and it's perhaps also a misrepresentation. But what I'd like to actually consider is the implications of disease causation and how we understand disease causation, with specific reference to the discipline of biomedical psychiatry, since I work on the anthropology and the sociology of psychiatry. So in this context, I think the sort of recent shift between the clinical and the research community, if we look at the sort of National Institute of Mental Health's move from the DSM's clinical nosology, which is like this recent move that happened in the context of mental health in the United States. I think this sort of project of treating the biological body as a machine, by which I really mean this shift towards identifying sort of neurobiological indicators or biomarkers of causation, might actually also have positive existential consequences for patients. And I think this is sort of counterintuitive for some of us, maybe, because we often think that such an understanding will actually lead to the neglect of patient perspectives. But I just like to point out here that patients might find it comforting to hear that their problems are actually related to the neurotransmitters, which would imply that they really had no control over them. And so despite like a lot of the debates around whether there is conclusive evidence for this sort of genetic causation of psychiatric disorders, the idea of disorders as brain diseases and sort of idea of reducing the mind to the brain or to the biological body might also be welcome news in one respect, because of this generally accepted belief that sort of physical ailments can be cured and will of course also be covered by health insurance. But if we move from this realm of understanding disease causation and diagnosis to the realm of treatment, and so if supposed neurochemical imbalances in the brain are treated with what are presumably disease-specific psychopharmaceuticals, going beyond the body and its sort of pathophysiological indicators or neurobiological markers would require clinicians to take the testimony of patients seriously. And so what would this sort of taking patient testimony seriously actually entail? I mean, I actually stress on this because I feel that there will be serious existential consequences for patients living with a sort of complex regimen of psychopharmaceutical drugs and their seriously debilitating effects on brain and bodily health, which are often actually dismissed as mere side effects. And so I think that's a problem to deal with that and how we manage side effects really, because this sort of reduction of the mind to the brain, which, as I've pointed out, might even be comforting for some patients. It doesn't always allow for possibilities to account for psychosocial and sociocultural causation. And of course, as well for the feeling states of patients as they sort of relate to their immediate social environment or to the lived experiences of taking certain doses of pharmaceuticals. And so I think from a clinical standpoint, it'll be interesting to sort of talk about this later, I think, because if the sort of disturbing side effects of medications are only to be managed somehow, while dosages, as supposed sort of chemical cures, will only increase or decrease with time, and thus patients often feel, and there's a lot of ethnographic literature on this, that patients often feel that their testimonies about their own lived experiences of taking these drugs are annulled in that sort of clinical encounter between them and their doctors. And so I think the question really is that whether this sort of relentless quest for neurobiological causation and thus psychopharmaceutical treatment can really account for some of these profoundly human lived experiences of patients. And so I think that there is, we don't need to be entirely pessimistic about that, because I feel that there is here a very important possibility of collaboration, which I think platforms like this really bring about. This possibility of collaboration between, I think, neuroscientists or neurologists or neurologically sort of oriented psychiatrists, and collaboration between them and ethnographers studying illness experience in particular, or even just social scientists more broadly. And because I think this in the contemporary moment, I think is very important, because it is now, I think, well established that, and we were discussing this the other day as well, that the human brain in terms of both structure and function is really amenable to change, and it develops in sort of endless interaction with the sociocultural environment. And so the sociocultural environment within which it is embedded, and this phenomenon, of course, is known as neural or brain plasticity. And so I think this tracing of neural processes is sort of germane to the new approach of the National Institute of Mental Health. And so it has been shown that these processes are increasingly, these neural processes are actually increasingly inflected by an individual's life experiences and social context. And so I think this actually can account for both this sort of mechanistic or machine-like character, as well as the sort of organic character of what it really means to be human, I think. Yes, I just limit my comments to that right now. Yes, thank you.
So, so when you speak about this bringing together of the mechanistic and the organic approach to our understanding of the human, I think what intrigued me and what interested me and fascinated with this, you're constantly using the term existence, right? What is existentially defines us as human. You want to just quickly say a word or two to sort of flesh that a little bit before I go to Priyanka?
Yes, yes, thank you, Dr. Chadha. I think, yeah, on the existential aspects of being human, I think I am personally sort of influenced by the philosophy of vitalism. And so, so I think that this sort of, it's actually, I mean, there's a lot of sort of contemporary debate on this, but I think what it would, for me at least, what would constitute to be human is a certain intentionality, and along with the sort of intentionality, possibility of both experiencing and expressing emotion. And so also, and so by emotional expression, I don't mean to, and I think I can come to this later, that I don't mean to conflate emotional experience with verbal expression. So I think while emotional experience might really be a sort of fundamental aspect of being human universally, the sort of expression, the expressivity part of it is not as universal, I feel. And so verbal expression need not necessarily amount to emotional experience only. Yes.
We'll come to that, but I think what is becoming a little clear as we are talking is that one of the things that we miss is the presence of emotion, you know, in the relationship between doctor-patient, in the diagnostic process, in the healing process, and you know, the that sort of terrain and domain is something which is so scary we don't touch it. Yeah. Priyanka, eager to hear from you and your thoughts on how do we look at this idea of the human.
I was actually very intrigued by, you know, certain words that were repeated, and I made a note of it repeatedly when Kavita was talking about it earlier. She was talking about subsets, and she was talking about separations. Later on, when Dr. Chadha was speaking, she again spoke about categories. And there was also a reference to economy that Kavita was making earlier about how this is such a time-saving sort of an approach when you know that you have 10 minutes and you have to make the best out of those 10 minutes. And what this led me to think about is I was thinking back to the research that was carried out by Tajfel and Turner, which was basically the genesis of the social categorization theories and so on. And in some of their early research, what they had established is, again, going back to the main question that we are talking about, how the other is perceived. And in their work, what they found is that in looking at the other, the out groups, there was always an attribution of non-human qualities to the out group. So sort of thinking about them as being less human or having more animalistic tendencies and so on and so forth. So that really made me think about something that Dr. Chadha was also referring to earlier. I think she was saying that there are these missing parts. We seem to have lost something in the conversation. And I'm thinking about whether they are lost in the hyphenated spaces between, say, biomedical or psychosomatic, mind and body. Is it in the spaces between these that we are losing them? We are familiar with the fact that the roots of the modern biomedical sort of model are in Cartesian dualism between the mind and the body, wherein the approach has always been of curing. Arnav was also speaking about this earlier, that the approach has been of restoring physical functioning and removing disease which is seen as organic malfunction, which is being diagnosed by the expert, the doctor, who again is in a time-saving sort of a mode, right? In all of this, I think we have to remember one sort of fundamental idea, that are we losing the whole in the search for these different parts, the mind and the body, the psyche and the soma? In all of that, are we really losing out the whole human? And to what extent are we really able to address that whole human when they say walk into a clinic? If we go back to the etymology of the word health also, which has German Anglo-Saxon sort of origins, it goes back to whole, hail, holy, wholesomeness, and so on. If you look at the Vedantic tradition within the Indian system, and I think I found this particularly, something to think about, it speaks in terms of how the spirit is sort of organized around these 5 layers or koshas. One of the innermost one is called the Annamaya Kosh, which is the physical body, around which we have the energy body, which is called the Pranamaya Kosh. Yet beyond that, we have the Manomaya Kosh, which is the emotional body. And then we have the wisdom body, which is the Vigyanmaya Kosh. And finally, we have the blissful body, which is the Anandamaya Kosh. I think one of the things that I've been thinking actively about ever since we started thinking about who is the human who's getting addressed in the clinic, is it just the Pranamaya Kosh, just the energy, the Annamaya Kosh, or the physical body? Are we, in any way addressing the emotional body, which is what Arnav was also talking about earlier? Are we, making any effort to reach out to the emotional, the wisdom, the blissful aspects of the human? Interestingly, there is also one researcher by the name of Siegel in 1986, a very interesting, sort of an idea that he talked about. He said, does the disease catch the patient, or does the patient catch the disease? So I think this brings a second kind of a problem into the purview, that who are we primarily interested in? Are we interested in the disease? Are we interested in the human? And if we are interested in the human, then we need to consider, not just the disease, which is the biological aspect, moving from a curing sort of a position to the illness, in the words of Kleinman, who differentiates between disease and illness and sickness. The illness aspect, which is the psychological and the experiential aspect, and the sickness aspect, which is the sick role that gets attributed and socially sort of constructed, repeated in daily interactions, and internalized as a representation of the self by the individual. So the approach has to be, then we are talking about a healing approach, which is about restoring a holistic, wholesome psychological health, and not just the physical body. I also wanted to share just a couple of examples. Maybe we can sort of elaborate on these examples a little bit further. The first one was when I had approached a doctor, a hematologist, in throes of pain, having gone through a very difficult episode. And I reached the doctor and I thought relief was near. I think that's what the patient feels when they walk into a clinic, that relief is here. And I explained my situation, and the doctor prescribed something to me, and yet turned around and just with a very, sort of nonchalant sort of a expression on their face said that you are a middle-aged adult with such and such condition. Pain is to be expected. And that was the end of the conversation. And she continued writing the prescription. Pain is to be expected. So this was one interaction where definitely I think the human felt that it had not been addressed. The other interaction was recently when my father had undergone a bypass surgery, and there was a review meeting a few months later, and we had gone to the surgeon, and the surgeon, my father was, sort of talking about some problems that he was facing, and the surgeon said, "Mr. Padhy, don't talk to me about this right now. Tell me, what do you like to eat? And tell me, why are you still in Delhi? Right now there is no lockdown and everything is opened up. Where are you going to be traveling to? Have you made any plans about that?" Um, I think in that interaction, was there a negation of the physical and the illness or the disease of the person? I don't think so. I think that's where the beyond was also being addressed. Something more, the mind and the way the emotional self also responds. I think that was also getting addressed. And I think that was my father, sort of came out of the meeting with a spring in his step. And I think that's the beyond that I would like to capture in our conversation today.
Thanks, Priyanka. Thanks for sharing the richness of our anecdote experiences through these anecdotes. Of course, I'm increasingly becoming conscious of the fact that when we're using the term human, probably we also need to become reflexive and ask ourselves whether, again, we are reproducing a very ideal sort of a human, even when we are talking about the whole human, even when we are talking about the complete human. I think these ideas and categories themselves will marginalize almost all of us at several levels. So I'm just wondering whether we want to move also. I mean, I know Beena is going to say, what are you throwing at me now? But I'm saying that what if we want to give up the idea of the human, and if we want to make practices more humane, we start talking about persons. Persons not these ideal complete humans, who are fragmented, who are broken, and how do we start building a conversation about including the expanding and extending the notion of the human to include various types of human beings, but also to bring the notion of the person centrally. So, now I think we start with, if this doesn't seem too structured, we start with our second round with Kavita. And Kavita has already spoken to some extent about how the body becomes very, very central in the early training of how to become a medical doctor to how we practice it. Yeah. So what I want to do, get us all of us to engage with is that in the construction of this biological body, or in the way we receive this biological body, or the way we analyze this biological body, do we see a social bias creeping in? Do we see that some bodies, like Sabah was saying earlier, some bodies are more equal than others? So the laboring body, for example, the woman's body, the body which is beyond gender binaries, the sex workers' body. Yeah, how do we handle that? How do we make ourselves more firstly aware of it, get out of this objective discourse that a body is a body, right? And that we are treating it equally. We are not really guilty or accountable for the biases that come in. Those don't come from here, they come from the outside. We are not responsible. Any Kavita, any thoughts? How do we address this question of the social bias in the way we look at the biological body?
I think the first step really,
Do we
Gita ji,
reproduce it? Do we tend to reproduce it? Do we make bodies unequal, even
all the time.
है ना?
I think we make humans unequal, persons unequal, ourselves unequal, bodies unequal all the time. I think that's the reality. And I think the first step is to become aware that this is happening. Because oftentimes holding that awareness with the acute sense of being present with that awareness is very difficult. We might become aware of it while we are talking about it right now. But to say that in my daily practice, I need to hold on to this awareness at all times, while my attention is divided in 10 different ways, I think that's the harder part for each one of us, at least for me. And therefore, and I think these are all practices, anything that we want to nurture, anything that we wish to do more of. One can train oneself to be like that, but where are the spaces? We need to make them. We need to be able to say, if there are X number of people who are willing to nurture this, there should be an intentionality and a practice that one could develop where this can be nurtured. And I think I actually think it is happening a lot. And because I work a lot with the youth, I find that I give them a lot more credit. I think they speak up, younger people speak up a lot more about inequality than we ever did. Our acceptance of it when we were in our teens or in our early 20s, our acceptance of the world for what it was, versus the questioning that I see, and I have the privilege of seeing today by the younger lot, there's a huge difference. And I think that's one of the movements that I feel which is making everyone question this a lot more. It's brought this to the forefront. And I think it's the harbinger of change. Being able to speak, make other people aware, have the voice that says, I'm going to question it right now. And the number of times I've been asked, I will come to you as a practitioner only if you tell me whether you're queer affirmative or not. Are you gender positive? Are you queer affirmative? These are not questions one could ask before going to a practitioner. This was not part of the discourse of choosing a practitioner to go to. But now you're asked. And now you have to prove that you are. And I think this is the reclaiming of the space of the doctor-patient interaction or the doctor-client interaction, where the seeker is saying, I'm equally important. So I'm going to check you out first before you start checking me out. And I often laugh about this with many of the young people and the parents who sort of bring them. And I say, listen, first time you can't ask me about her or him. First time they're checking me out. Now they will decide whether it's okay to talk to someone like me. So don't expect at the end of the first round of conversation to come and tell me kya bataya unhone, what did they tell you, and what is the diagnosis, because they are choosing to see whether I'm trustworthy to speak about and bring their whole presence in. So for me, a lot of the time, this sort of segueing from what we were talking about as human is that we all carry so many different parts of ourselves as a whole sometimes in certain spaces, and in other spaces we choose not to bring certain parts of our identity in. And I think that's true for all of us. Who is making that choice? And I do think that the patient or the client is making that choice, but it is based on several factors. So one of which could actually be how welcoming the space is, how welcoming is the social discourse around a medical interaction, who is this person? I have checked them out now. So a lot of time the young people have told me, oh, we saw you outside, playing with this little 4 or 5 year old, and we thought, she's not bad, she's quite kind. So they've decided then that I will go inside, I will speak to this person. So I do think that the bringing of the presence on both sides is a huge factor in the way that the inequality that we were talking about can be, I don't think there's a solution really in only this, but I find that many young people a few years later will come back and say, doc, we remember these words. And sometimes I've really struggled with what's going on with this young person. Am I being able to help them or not? And I've had the privilege sometimes of seeing someone's journey, being witness to it, and walking with them for many years together. So much like Bina was saying in the beginning, that there are chronic life conditions. Many times mental health is also like that. But many times young people choose to come back after a few years to say, you said that. And I still remember when I asked one of them, I said, what made you keep going really? What do you think helped for those years? And she turned back and said, doc, you were persistent. If we didn't know what's going on, you said you're not going to give up. And that's what I valued. So I was a really bad diagnostician, clearly. Neither did she know what was going on, neither did I. And there were multiple variables. But she said, you persisted. And these are the kind of instances that sometimes shine through for me about what does my presence in that interaction really mean? Am I bringing myself as a doctor? Am I bringing myself sometimes as a listener? Am I bringing myself sometimes as a diagnostician? Am I bringing myself sometimes as an elder? So many different parts, and they may vary from time to time. And what is the young person or the little one? So here I'd like to also talk a little bit about the larger concept of neurodiversity. When we talk about unequal bodies, when we talk about invisible parts of somebody's identity that is being brought in, I think for me, largely my practice has been around children and youth. And when we look at children, I think the voice of a child and the terrible inequality in an interaction that a child comes from is, I think, something we need to change very soon. So in a medical interaction where a child is coming or being brought, more often than coming, they are being brought, there is no sense of agency most of the time that the child has, neither in choosing who the practitioner is, nor in whether I will go back there or not, nor in the kind of information they're receiving about what's going to happen next, or information about their own body in an appropriate way. This is a huge inequality in the body, which is not even, just you see the size of the body and you assume they are little adults, or you assume that they cannot be told all of this, so we will not tell them anything. And that's not necessarily because they should not be told. It's possibly far more because one doesn't know what words to use and how to tell them in an appropriate way. So I think that's one big thing, which is a pet peeve with me, which I would like to bring up. And the other thing is neurodiversity and the amount of differences. So we see children, for example, with autism or with ADHD, or a child with learning differences. And the paradox is that the body looks fine, just like another body of another 4-year-old. But there is this plethora of hidden differences that immediately produce inequality. This child doesn't speak, this child doesn't make eye contact, this child doesn't do well academically, this child is badly behaved according to the teacher. All these are beyond the body, because in this realm of neurodiversity, especially in children, they might get such a beautiful child, such a lovely kid. There possibly can't be anything wrong, such a sweet child. So I'm just, while we talk about the body and the beyond, I think a lot of what we see as neurodiversity or mental health issues are not even defined in that concept of body. And I'm deviating a little, but because it's occurring to me, I'm going to say it right now, that medicine per se has over 100 specialties. There is one for the mind. So however much we may say it's the mind and the body, It's the body divided into 100 parts that we are going to study at the micro level and super specialize in and zoom into the cellular level. And for the mind, we have one specialty. And it's not the best regarded one. So it's because it's not entirely scientific. And there is a hierarchy even within medical specialties where psychiatry doesn't come near the top or anywhere near the top. Yeah, it's just started rising up from the bottom, but I don't know where it is right now. But I think the inequality or the sense of real sort of, I don't know if they're just power equations. I think it's much more than that. It is about how we hold certain bits more valuable than others. And not just mental health. I think the sexual and reproductive health is the other part, which is somewhere near the bottom. And we don't talk about it. Although it is a medical specialty, people who say I'm a specialist in sex therapist, or I'm the sexual and reproductive health specialist, they're not near the top. And yet it's such an important part of being the human for most people. So I know I've deviated a little bit from the original question that Gita ji you asked, but so I'm going to stop here for the time being and see what the rest of you have to say.
Not at all. Thank you. As Beena always says, there's no diversions here. We should try and go as free-flowing as we can. Let me invite Bindu now to sort of dwell on this question, Bindu. How do we look at marginalized bodies? How do we first detect that there is, I mean, it's obvious there's so much discrimination in the way we look at social bodies. Yeah, your work in disability, your work in also looking at different intersections of caste, of sexuality. How do you this question of the reproduction of social bias in considering the biological body?
Thanks, Geeta. I think at this moment, listening to all this really wonderful and rich conversation, at this moment, I think I'm only thinking aloud, because I don't think I have. I thought I have come with some definite ideas, and that in fact, got ruptured really, and that is much needed. And also, thanks, Kavita, for that really the bringing the conversation and particularly on neurodiversity. And this is something I've been recently engaged in research, looking at particularly trying to engage with parents with children with neurodiversity, trying to understand the world of particularly coming from the perspective of parents. So, perhaps I'm taking that question from where Kavita stopped, Geeta, and then I hope I would try to make some sense of it. Would be in a world in which we live, ideology of ableism. The ableism is the determining ideology. It is not just when I say ideological, it is not somewhere out. It exists in the very built environment. When I speak my language, how I constituted myself, and lot of things comes in. It is not only the materiality of where I located, but when I say my caste, class, region, the language I speak, all of that comes and constitute that ideology of ableism. And perhaps when Kavita talked about looking at the world of neurodiversity, and particularly we are talking about that the spectrum, the large spectrum of invisible disability in that sense, and then attempt to look at or try to make any kind of meaning making in that context. Our standard and standpoint becomes an already existing ableism, the ability discourse, because we don't have another model. And from that, you try to bring in and either get adopted here, you get fit in, rectify, go through. So that idea of agency doesn't at all come in. So let me see whether I can give a much more concrete example to that. For example, the campus where I live in I live in an education in a technological campus in Bombay. It's considered one of the premier institutes. Uh, so even recently they have changed, but I remember to enter into the academic area, they have been kept. There is something called the what is it called, the cattle barriers, right? That the road which has been that is something which is kept. And from an outset, it looks like a completely neutral thing. You wanted to bring in the demarcation. And then the question would, what about when people, even it is not only about the wheelchair user, it's, anyone can find it, navigating that space could be really, really difficult to think about. And then the question would come in, but it's okay, we are here. If someone comes in, then we can help them out. It comes with this idea of charity, it is come with the idea of paternalism, we would help you out with that, our own privileged context. We don't even think about is there something fundamentally wrong with that space itself? And we are talking about an institute that has been there for whatever 50 plus years and built on, and it has been the case with many others. So that the idea of getting access, when we are talking about accessibility, when we try to get inclusion, some of this thing comes very, very starkly to our life. Now, how do you? And it is not only about the material space; it is about the idea of inclusion. Now, who is considered as again taking it from where Gita, the first question about who considered as human, who gets that complete and full participation, who becomes that can participate as a full human, and holding all citizenship and enter into that, entering into that discourse. And from the outside, you would say that of course we can make other ways to get access to that. Look at any other, for example, various other campuses I've seen. If you try to think about where would you see the ramp? It is not there will be a main entrance with steps. You have to go behind the building. Main thing to think about. Why are we thinking about becoming something to fit in? It is outside. No, there's an ideal human body over here. So anything we will make provisions with our paternalism, with our privileges, and who are these we who are making that decision to do that? So I don't know whether it is directly addressing the question which you raised, Geeta, but I'm trying to make sense of this idea of ideology of ableism that overpowers the way in
Yeah,
which it is in the context of that
absolutely.
yeah, how the way the discipline make it, how do we see the material space, all of that would come in. So for example, let me try to see whether we can bring in some other context to look at how do we see some of these biases that comes in, and then that's in producing then stigmatized bodies of that context would be. Now, for example, I've been engaged with this idea of gendered aging body for quite some time. And then one of the initial entry point for me to look at, I would attempt to say that no, that aging doesn't necessarily happen in that linear form. It is not that an inevitably linear, segmented aging that happens. And then the other question would come in, yes, that is true. Aging can happen in different contexts because people age differently. But that is not the point. The point here would be it is not that whether it is linear or aging happens differently to different people. The problem here would be maybe at this level, I'm thinking aloud at this uh, context. The way we try to think about the body itself would be already, it comes to be through a lot of discursive context. When I say discursive context, there are a lot of hierarchically produced power relations that makes us what we are. So it is not that the body over here, and then people age differently because when someone enter into a tribal hamlet or somebody enter into a privileged upper caste household, people age differently. The point here would be the idea of the biological body itself is, I know I'm perhaps borrowing it from the idea of performativity from Butler to say that it is getting materialized through this discursive context. And that idea of that discursive hierarchy needs to be looked at much more carefully to come back and
Absolutely.
what bodies are and how bodies
Yeah.
are produced. And it is not that, so in that sense, I won't say that the material body over here and then there is social construction, because that's what
No,
really
sure.
disability studies have done, that we moved from medical model to social model. I would say that let us come back to bodies. Let us come back to bodies and think about how that bodies comes to end to a number of exclusions and hierarchies that get produced, and how does it get materialized. So, do I have more time, Gita?
Well, we could come back because
right.
Bindu, we are already actually
Yeah.
I don't even know whether we'll be able to have the third round well, but we'll come back. Sabah, just quickly, I mean, through your work, how, I mean, I'm sorry to say quickly, but
I think Bindu has brought up this, the stigmatized body. For a second, I want to talk about the non-stigmatized body. And by that, I mean the body of the doctor. Let me say this, that, I mean, it's very interesting when Kavita says, like, I mean, she is a doctor and sometimes she's a patient, right? But in my own research, where I study between science and religious ideas, right? It is, we think that people who go to faith healers, right? They are not scientific. They don't understand science. They are not objective enough about their own problems. And then you turn around and, you see a doctor in the same shrine, doing some kind of religious practice, which is like as if the problem of those faith healing, like both practitioners and devotees. And so, like, of course, what every doctor in this workshop will know is that doctors fall ill. So they have, like, they are, first of all, just human in that way. Secondly, they are themselves like their own ideas about their bodies, their own bodies is full of cultural ideas. It's full of religious ideas about, what it means to be healthy or not, right? And but in our practice, right, that is where it becomes somewhat different. Like, our practice is scientific, but our lives are not. Like, I don't know any scientist who is scientific in their, like, in the way of like being this absolute scientist, right, in their own lives. So, like, they have some ideas which are borrowed from cultural ideas of what it means to be a man or a woman, or what it means to be like, belonging to a certain caste. And so I think the body of the doctor itself should like allow us to kind of, like look at this differently, that, like the doctor's body is also has the same problems as the problems of the patient, but our discourse is scientific or superstitious, and why are there these slippages, right, between how we talk about ourselves and how we talk about other people. I think I'm just going to say that.
Thanks, Sabah. I'm going to come back to that in the third round, this whole question of faith healing. But I think what you also brought to me, at least what struck me, is that in medical school, for example, unlike very esoteric scientific institutions that some of us have looked at, what we are seeing happening to Dalit students is already predefining, who can be a good doctor. Who can be a doctor, who can be a good doctor, and the possibility of stigmatizing a doctor's body begins probably in medical school itself, and we're seeing a lot of that. Priyanka, I'm going to come to you to understand from your work, and how do you see, say for example what Bindu was saying, how do you see this whole conversation about the social body and the biological body separation, bringing them together?
So, when Dr. Bindu was speaking earlier, she talked about how even in terms of planning, say a building compound, the able becomes the default position. In my interaction during my research work, field work, when I was interacting with families and parents and of children with chronic illness conditions, I think one of the words that had a maximum sort of preponderance was normal, both in terms of the parents using that word repeatedly and doctors using that word repeatedly. They would say it and then they would want to retract it, almost as if, there was a little bit of an apology for relapsing to that default position again and again. But I'll speak first about the parents. And what was very interesting is that if I would ask them to think about a future for their child and a vision for their child in the future, what do you want the child to have in the future? They would say, बस हम चाहते हैं कि वो normal हो, normal life हो. This is what they would say, that we would want for the child to have a normal life. Interestingly, when you would ask them to describe the child, they would say normal ही है, सब कुछ जैसे बाकी बच्चे करते हैं वैसे ही इसका भी चलता है, normal ही है. So it really made me think about between that normal and this normal, what is it that is missing? And through that interaction, that those interactions, some of the things that came up is somewhere there is certainly a sense of loss of the imagined child and the imagined childhood that that child would have had. And parents are actively and families are actively grappling with that. What is also replicating this particular, sort of a internal dialogue for them, where this is getting reinforced from, is that they are also hearing it from everyone around them. So whether it is the doctor community or their extended families, they are repeatedly hearing this comparison against the normal. And, very much in conversations with doctors also, that came up as, a word that was repeated. Now, the other, thought that really I thought was quite striking is when Kavita was speaking earlier about how, the same person has a different experience across the table and on this side of the table and that side of the tables. The reality shifts drastically if you are the patient and if you are the doctor. So, somewhere that power, the inherent power and the powerlessness of these positions, I think that we are making a big step if we are even acknowledging that. Even if it's entering into our conversations where we are talking about this particular power dynamic and examining it more closely, I think we are making a lot of difference there. With particular regard to, just one last point, with particular regard to chronic illness conditions, one of the things that people were also grappling a lot with, again coming from the social inherent biases, we want these people to be normal so that they can work normally in employment, and there is no discrimination. But equally, we don't want them to be too well, and that's because that defeats the idea of the sick person that society holds in their minds about what a person with the illness looks like. So if you are looking too well, then that also becomes a problem. And therefore, this individual has to walk this fine balance between being well enough to be employed and well enough to participate in social life, but not being too well that their entire illness experience gets negated and completely questioned.
Yeah, this sort of will bring me to the question later with you on resilience. Arnav, building from your comments in round one, how would you like to enter this question about, is the social body reproduced in the medical discourse?
Yes, thank you so much. If I may just very briefly just respond to some of the things I was really sort of struck by that the previous panelists spoke of. Just as an aside, I was just intrigued by Kavita ji's comment about the body actually being divided into 100 parts, but one speciality for the mind. And so I think, and when you're referring to that position of psychiatry in the hierarchy of the medical disciplines, I think it's that position, if I may, that sort of position actually culminates sometimes in this sort of inability, or if I may say, the limitations of psychiatry to really go beyond the body now, because now, because of this supposed insecurity of psychiatry within this hierarchy, I think the discipline itself wants to move more and more towards neurobiological indicators and pathophysiological indicators, and thus psychopharmaceutical treatment. And so that's one part of it. And the other thing that Sabah ji mentioned about practices as scientific, but the lives of the clinicians as not. And so that in that context, I just very briefly just like to move to the more sort of concrete setting of the clinic itself and the life worlds of clinicians. And so I think particularly in the context of South Asian psychiatry, I think it's now well known that the family and psychiatry actually increasingly lean on each other. to ensure patient compliance. And so because clinicians also work within a particular social environment and they're embedded in this particular social environment, there is sometimes like this reinstating and reinforcing of what I see as strained sort of socio-emotional family relations, which actually may have contributed to mental illness in the first place. So I think this is also particularly relevant when you're talking about the reproduction of social bias. I think it's particularly relevant in the case of women, because there's sort of gendered vulnerability in both natal and conjugal families makes this a serious sort of problem to contend with. And I think so the fact that diagnosis is actually made on the basis of presentation of symptoms as embedded in caregiver narratives, and this is what a lot of the panelists were also speaking about. And so I think this actually tells us more about the subjective experiences of caregivers than of patients. And so I think in this context, now there are, of course, several studies, anthropological studies, which argue that psychiatric patients in countries like India have better clinical outcomes owing to sort of enduring family and kin networks and stronger socio-emotional relations based on norms of interdependence. But I think, at least from my perspective, I don't think we can entirely rely upon these findings as sort of unproblematic, because I think it is also because it is often within these supposedly strong and intimate, enduring sort of networks of kinship relations that psychiatric crises, particularly for women, are actually generated in the first place. And so then these strained familial relations may have actually contributed to illness in the first place, and they can sometimes be reinstated in processes of treatment because clinicians themselves are embedded in social environments. Yes, so that's what I got.
Yeah, absolutely, Arnav. I'm going to sort of use my prerogative of moderator, and at the last round, I'm going to truncate slightly and then open it up for the closing comments. And I'm going to truncate it by the 3 concepts notes that I got. The last round we thought about is beyond. And as in our initial preparatory discussions, Kavita had raised this question, we need, a lot of us within the practitioner's domain don't even ask this question of what does a beyond look like, or what do we mean by the beyond and all of that. Yeah. And so just asking that question becomes crucial, because we are so deeply encultured into looking at the body the way all of us have spoken of. The 3 words that I'm going to pick up on from 3 panelists here, and I'm going to, from their concepts note, I'm just going to ask them to talk about that in terms of the beyond. And so I'm going to pick up on Arnav's non-verbal music and the role that it plays on testimonies. I'm going to pick up on Priyanka's concept of resilience and the study of resilience and what that means. And I'm going to pick up on Sabah on faith. Yeah, and faith healing. This is not a comprehensive discussion, right? It's a conversation. So let's start with Arnav. How do you think that taking on board non-verbal testimonies is a way of, say, going beyond the normative body of the ideal human that we make in medicine? In order to, I would say, in order to take on board the form of human, which is not endowed with this essential quality of being verbal, which is associated with the human.
Yes, thank you, Gita ji. So I'd actually sort of approach that question by thinking about what it means to go beyond the body or the bodily, as also implying going beyond the verbal, like you just said. And so I think this is important because patients might, and this has also been spoken of already, that patients actually might be unable to express themselves verbally owing to underlying conditions of psychopathology, or in fact, sometimes also because of the very real fear of being misunderstood. And so it might really be a problem of social communication. And so, and even if they can, I feel, as psychiatric patients, like I'm specifically talking from the point of view of psychiatry, they may not actually be taken seriously because they are supposedly suffering from significant cognitive or functional impairment. And so, so the point really is that even if like well-intentioned clinicians are genuinely concerned about taking patient testimonies seriously, which I'm sure a lot of them are, and we shouldn't assume that they aren't, they may actually lack the sort of necessary clinical acumen or training to access subjective experiences, emotions, desires, and intentions of patients, which often I feel gets black boxed because these are presented in terms of narratives of the caregivers. And so, I think in this context, so the sort of the overuse of psychiatric characterizations and labeling may make it seem like patients' sort of self-identification and self-definition is not as important, or it's less important. And so in this context, I feel that thinking of the non-verbal, and by non-verbal, I mean like in the broadest sort of conception of it, as including art, writing, poetry, music, and so on. I think of this as significant not only for patients, but also for practitioners. And I think for patients, the non-verbal actually may be significant, of course, as an alternative sort of mode of expression and communication. But I think it also offers possibilities of re-identification as being more than merely sick or ill. And so non-verbal modes of expression are actually important devices for clinicians as well to rethink perhaps diagnostic criteria or that are premised upon impairments in utilizing verbal and bodily modes of expression and communication. So for instance, I'd just like to very quickly just talk about several ethnographic and autoethnographic studies of psychiatric patients' poetry or songs and writing. And what these studies actually point towards is that there are certain possibilities of these alternatives or non-verbal modes of emotional expression, as well as the problems that arise when we conflate emotional experience with verbal expression. And so what is pointed towards here is the need to sort of discern the origins of emotional outbursts, for instance, as embedded in these modes of expression, rather than sort of dehumanizing patients and discounting their experiences, which in some context can actually also lead to the denial of care altogether. And so, sorry, am I running out of time?
No, go ahead.
Yes. And then in this context, it's also been found that patients themselves actually utilize their own knowledge of popular cultural phenomena, including films, literature, and music, to apprehend subjective experiences and engage others in the interpretation of these experiences. So social communication then can actually become a possibility. And they often express, like I'm again speaking of some of these studies, that they find that patients express frustration at the lack of utilizing cultural artifacts in therapeutic processes. So I think it will be interesting to see what clinical practice may look like if alternative modes of expression and communication are tied to cultures of care very seriously. And so since this may be relevant both for processes that are entailed in arriving at diagnoses based on verbal expression, as well as for ways of ascertaining therapeutic efficacy, which I think also is very important, because we often sort of ascertain therapeutic efficacy in a particular way, and we don't focus as much on the patient's experiences and perceptions of those sort of transformational changes which occur during treatment processes. So I think that really is a possibility of that is opened by the nonverbal. Yes.
Thanks, Arnav. When we were talking about this earlier, Kavita had said that, but actually, we do use a lot of non-verbal testimonies. I don't know, maybe I'll ask Kavita to come in here. Is it only for therapeutic use, or as what is fascinating, what Arnav is saying is that can we use these non-verbal modes in our diagnostic practices, not just in providing therapy, through music or art or literature, but can those which are produced by the patient, can they be used as diagnostic? Are they used?
Certainly they are, both as as well as intervention, especially in the child psychology and psychiatry field. So, I mean, there are entire sort of disciplines of, for example, play therapy, where, the therapist may not even speak much, where the child is not necessary, there's no demand to speak in that hour. They may be playing. Yeah, so there may be puppets, there may be animals that they're playing with. There is music therapy. We have at least 2 people who do music therapy, so that's more therapeutic. However, especially in the diagnosis of trauma-based psychological sort of disorders or problems, this is often the case for expression and leads to a diagnosis. So at least in the realm of the younger lot, this is certainly theater. There are entire practices based on this. So there's something called neurodramatic play, or which is only based on this, and it's based on the attachment theory and how this is, and there's play therapy, there's music therapy, there's arts-based therapy or ABT. There is expressive arts therapy, which encompasses several things. There's movement therapy. So there's a whole lot of things. Yes.
Yeah, whole lot.
In many ways, it's diagnostic, and in many ways, here I just like.
I guess that's a window that we, that through which we can go to what we are talking about in terms of the beyond.
In children, oftentimes we don't necessarily distinguish the two very much. Sometimes the diagnosis, we don't wait for the diagnosis.
Yeah.
Also, that with the understanding that once the child expresses, often through non-verbal means, he will actually come to know.
Yeah. I didn't see that there was a message saying, can we jump in and raise our hand and ask a question? Please feel free to do that, Sabah. And I'm going to invite Priyanka. Priyanka, the term resilience, my God, every patient. I mean, I have several chronic conditions, and I'm all the time obsessed with this idea of resilience. Can you talk about it a little bit as a patient, or what is resilience? How do we?
Right. So
it is going beyond our condition.
That's a really tall task that you set out for me, ma'am, when you're talking about resilience. In fact, the definition itself is so contested, and it is there are so many layers to it. But one particular aspect that I want to speak about when we are talking about what might it mean to go beyond, there's this particular understanding which has come from the work of Michael Unger, who says that in the context of exposure to significant adversity, and it could be any kind of adversity that we are talking about, resilience is basically the capacity to be able to navigate to resources that sustain your well-being, and the capacity both individually and collectively to negotiate for these resources to be provided and experienced in culturally meaningful ways. When we are speaking about illness experience in particular,
but isn't that being demanding, or is it being resilient?
I think a part of being resilient would be to demand for what you think is going to sustain your well-being. So the recovery of that voice or expression of that voice is probably also an aspect of the resilience, both of the child, the family, and so on. I was also wanting to speak a little bit about how the doctor, particularly in case of chronic illness conditions, which is where my study was located, the doctor becomes, almost to use the metaphor of a journey, the co-traveler who's walking alongside you. These are not illnesses that are going to kill you. These are illnesses that you are going to be living with for a long period of time, right? And therefore, the doctor becomes somebody who's walking alongside you. I'm, one of the main things that, of course, apart from addressing the physical distress of the patient and providing treatment to the illness condition, more importantly, I think one of the things that the doctors address, that I have witnessed doctors addressing, is the will to meaning, to borrow Frankel's term, will to meaning that, all patients would display, especially following a diagnosis, an effort, a basic motivational force to try and understand what is happening. The basic process to try and make sense of the illness experience.
Yeah.
And I think that's where the doctors come in a big way, apart from informational support, also emotional support, and even sometimes resource support, which will just try and put the entire idea of what this means. It can be so confusing for patients, particularly newly diagnosed patients. I have witnessed that firsthand. The diagnosis of, say, something like thalassemia being landed on parents, and they are not able to understand what does this even mean. If you say that a blood transfusion happens, okay, I will transfuse my child and I will put in 2 units of blood, then what do you mean that he needs it again in 15 days? Where did that blood go? What happened to it? So even making sense of these experiences, and for largely unaware populations, people who don't know anything about it, one aspect is awareness, but also to be able to reach the person where they are, meet them there, and being able to explain to them that this is the reality that is now the new normal. How do we establish the contours of that new normal?
I mean, yeah, I think what you're saying is actually very wonderful, in a way counterintuitive also, because resilience we often tend to think as, surrender, but what you're saying is gaining control, being able to give meaning, being able to get information, and through that actually developing a deeper understanding of a condition and then coming to terms with it. And probably our systems are not doing that enough, respecting that space. Yeah. Okay, Sabah, we are going to, again, I'm taking the prerogative of the moderator. We are going to end with the question of faith, because there's, it's so big, no? I mean, so I'm not even going to try and frame it. I'm just going to leave it to everybody in the panel and the audience to figure this out for themselves, and we're going to have Sabah talk to us. What is this?
So I think first I would like to say that when I say faith, I'm not talking about religion or spirituality, because I think that faith is an expression of belief that something will work for you. So I think that patients come to doctors with faith that, this treatment will help, right? And they will come back and again if they believe the doctor can cure them, right? Now this works, of course, even in like a non-medical setting where, faith healers without any scientific or, formal training can also try to heal people, right? And there again, though, this aspect of faith, right, that this will cure me, this will heal my problems, makes people go again and again, right? Go back to that treatment, go back to whatever is that process. And faith then is actually incredibly, it's a very strong process in the, in it within treatment, because it means that the person, the patient or the subject is engaged in doing something, right? And in a process of hope. But so there are many places in which where we place our faith. I think that not all those places are safe places for everybody. So for instance, when Arnav says that family can be both can improve treatment outcomes, the presence of family, right? It makes prognosis better. But at the same time, family might be the problem, and it might be creating of symptoms for certain groups of people. In that way, people go to cultural resources for some kind of, with some faith, with some kind of hope that things will get better. And again, here, culture is, I think in another way, it is it has a dual thing that, of course, within culture, we might find resilience, we might find, the tools to fight off the adversities of life. But culture is also the spaces where we are finding so many problems coming in, like in our own society, casteism, patriarchy. So culture is not necessarily a safe space, right? I think the converse is also true, that science is where we think that okay, science is proven, so we can trust in science. And yet science is not has as many pitfalls, because of course that this is also and I think Gita ma'am, you would be better to talk about that. But science is it's embedded within a sociological process, and so scientific facts are also social facts, or that interaction between them. So for me, faith becomes a way of interrogating what people are, what people want from their treatment, and that why they make choices which seem to be counterintuitive in that way. They sometimes go, it seems away from what might be actually working, but they are getting something. And I think therefore medical practitioners and mental health practitioners have a lot to learn from faith healers, because how to keep the person, the patient, alive in the treatment. By alive, I don't mean biologically alive, but to feel like that they're, that what they want, they are going to get from here, and that they can get better. And even if they don't get better, because actually not everybody who goes to a faith healer believes that they're going to get better, but they have at least a momentary sense of calm, sukoon, ki, like you sometimes, only in the act of submission that they do to this higher power, this Baba or whatever, there is some return that they are getting. And I think these are important aspects in treatment itself, not only in faith healing, right? But faith healers use it very, very well. And I think some of my research is trying to understand, like, okay, so if faith healing has any kind of, if it has benefited anybody, even to a small extent, how can something like a placebo have such an impact, right? And I think that's, at least for me, like faith, I say faith healing, but I also say faith is healing for a lot of people. And I think that's something we should be like, medical practitioners should also be bringing into their practice, into their work.
Thanks, Sabah. Thank you so much. I think this was a very, very initial conversation and probably went in many, many different directions, and I've sort of lost control over it. And hopefully, we'll do something more.
I wanted to speak at so many points, but
I know,
I didn't know where to
Veena.
start, and because it's huge. So starting with Sabah, just quickly, I completely agree. I think there is so much to learn from that. It's not a conflict between, because there is this debate coming so often between different types of healing, and I think that is a very summative way of saying all of it, that there can be good and bad from different places where we put our trust in. So where we put our trust in, and like Priyanka said, she's following with chronic care patients, and some of them have, for example, if I may say, type 1 diabetes, and all young kids who are diagnosed with type 1 diabetes, the initial struggle with what is happening to my body. And more importantly, after we have explained what needs to be done, it's why it happened, where is the fault exactly, not in biological terms. They just keep finding the answer in something. And most of them would go for faith healing, every one of them. I mean, it's so remarkable that I know that they will go, and I tell them that I understand that you will go and find answers at different places, but continue your insulin. And so it has to be a conversation like that. So I think that's probably important in building resilience also, because you put your faith somewhere else, a lot of conflict, at least for the time being, till you're struggling with all that gets resolved. I think maybe it works that way. I don't know.
Yeah. Every time now I talk about homeopathy to many of my very, very rationalist friends, they say, oh, this is placebo. And I said, it's okay. Let's go for an integrated system of medicine and health where I have at least the freedom to combine systems. Bindu, any quick closing comments?
I really don't know whether I have a closing comments. It's really rich.
Or anything you want to say.
I just wanted to say that no, though while we are looking at beyond the body, I also wanted to come back to the
Come
body,
back to the
to look
body.
at body as something. It is not a standalone. It is not a historical. It is not something discrete. So in that sense, I wanted to pay much more attention to this idea of local biology and the context. And I think that connects with many of this conversation we had. And one more point to think about then, coming back to looking at body, I think in terms of medical professional, I also would like to see the diversity of medical professionals there. To, for example, to think about when I come to the clinic, I get to see somebody I can associate with my mental state. In that sense, somebody with diverse embodied experience, more medical practitioners with different contexts. So that kind of representation, that also matters. I guess all of this I wanted to think about in terms of
Yeah,
humanizing people.
absolutely.
Yeah.
Yeah. So I'm going to just close it by saying that I feel now that while trying to humanize medicine theory and practice, we have to go beyond the notion of what we have of the human at the moment. We have a very idealized notion of the human. We have a very normative notion of the human, of the human being this and that and that. And I don't think that notion of human is going to really work for us. But probably what we need to talk about is the personhood of every human being who comes, and how to ensure that they live their life to their maximum of their potential, whether it is somebody with cerebral palsy, whether it's somebody with autism, whether it is people who we will otherwise consider less than human simply because they do not fit into our original conception of human as being this perfectly endowed creature. So I think maybe we also need to talking about personalizing medicine and to bringing human personhood of every patient and every doctor, and to bring their personhood into it, so that they can realize their full human potential, whatever that might be. Yeah. So I think we'll end with that. Bina?
Yeah, I'm Beena. So I'll quickly taking from there, and because it's a message for physicians also, I think what I gathered from what Bindu said and what you are saying right now is that we need to be a little more accepting of the brokenness, which I mean, in my case, not there is no change in the body. It's just, as I said, biochemical change, some change in values. We are even going to that level. And the burden on physicians to make everything perfect should be little less. So I think we should start accepting the little less perfect forms of whatever comes to us, the messiness of it, and that should be better for us also as human beings. It will make things easier, I think, for both the sides. Yeah.
Thank you, Bina. Thank you, everyone. Thank you, Kavita. Thank you, Bindu. Thank you, Sabah. Thank you, Priyanka. And thank you, Arnav. It was such a delight to actually have very young scholars come with so much understanding into the discourse. And thank you, Bina, for making this happen. And we'll see where we can take this. My goal would be to go to the medical schools and try and see whether we can make awareness workshops and other things. Sabah, yes. You have your hand raised?
No, I was just doing my appreciation to what you got.
Okay. Of course, as I said, I think, when we talk about structural windows that have to be open, since we're all teachers and pedagogues, I still feel it's at the level of pedagogy. And I feel if we can work with
Another conversation. Huh? This is like done, huh? Here. This will not be a part of the recording, no?
whatever. I mean,
Yeah. So if
I'm
it's a
happy.
video, then I think.
Okay. Yeah. No, it is still recorded.
But we
Yeah.
don't need to
No,
add all
so
this, no? And
yeah, we end and say
then
that we
I
hope
can
to
open
work
it.
together for various things. You can edit it. You can edit
One
it.
thing, Abina, I'm just
Yes.
so that when you ended with accepting our brokenness, I was thinking it is not only accepting our brokenness. As medical professionals, we are also broken sometimes. So in that, the diversity we
Oh, so
bring
one
to
person came to me.
yeah.
Yeah.
So
And she said,
where do I
okay,
then relate?
yeah, no, I think we are equally judged that way. So once we start accepting our brokenness, then only we'll start accepting their brokenness. And one of the common things which I treat is people coming with they want to reduce weight. That's the thing I see every day. And now I've started asking them, why do you want to reduce weight? Even I like, no, that's the thing, because I don't want them to lose weight anymore, because that's how it is. But they would come to me and say, okay, we went to the other doctor, and the other doctor himself or herself was not fit. And therefore, I mean, so there was at one point me and my nutritionist. So when she came to me, she said, do I need to lose weight before I start sitting in your clinic? I said, no, you don't need to. And also have not so finicky about going to walks every day, which I used to be. Actually, I was trying to keep myself at a level because I wanted to advise people. How can I tell them to do a certain thing which I am not doing? But now that is relaxed a little bit over a period of time. It took me some time to accept my brokenness before I can allow them to, because if I am very strict with myself, I'll place the same kind level of judgments on others. It's I think both ways. It's probably not as dissociated usually, because the conversations happen just like that. You don't plan, you don't, you do what you're doing every day, you speak that only. And I think the values immediately reflect. You can't change it in those quick conversations. They just come out. So yes, so we have to accept our brokenness, and that makes things easier. Good night.
Thank you, everyone.
Good night. Good night. Thank you, everyone.
Thank you, panelists, for being there so late in night. I know we are running very late.